All right. Hello, everybody. Gavin Dunn. I'm the program director here at WashU. I'm joined by Dr. Josh Osbun, who is our associate program director, and also Sophie Church, who's our program coordinator here at WashU. And we're really excited to be a part of this virtual presentation. Dr. McAvoy is a pediatric neurosurgeon in our department, and really coordinates our medical student experience. And he has assembled a terrific series to showcase, what we are as a department, what we're doing, and also provide opportunities to learn about us in a forum like this. Last week, our residents discussed and reviewed their experience going to Ireland. And today, Dr. Osbun and I will talk about really the program itself and our faculty and WashU and our medical center. And so we've got a formal, not formal, but a slide-based presentation to start off with. And we'll try to get through that in the sort of 25-ish to 30-minute time frame. But Dr. Osbun and I are going to tag team. We're going to trade off here. So we'll be monitoring the chat here on the side. So when one of us is not speaking, we'll do our best to answer some of those questions in real time. But again, we'd like to kind of spare plenty of time at the end to have sort of a real-time question answer for anything that might come up during our presentation. So with that, I'm going to share my screen here and get going. So like I said, we're the program leadership group here at WashU School of Medicine, and that is in fact geographically located in St. Louis. And we can't really talk about the program without talking about the community and our associated institutions. So WashU School of Medicine is consistently a top-ranked medical school. Certainly for NIH funding. We have a very comprehensive research community and attendant facilities here. And just as an example of that, we have a very large MD-PhD program here, of which I am one of the alumni. There are just some pictures of some of our physical plant here at the bottom. So WashU staffs Barnes Jewish Hospital, which is the flagship hospital of the Barnes Jewish Christian Healthcare Network, which is one of the largest academic healthcare networks in the country. Barnes Jewish Hospital itself has nearly 1,400 beds, very, very big hospital, level 1 trauma center, very highly ranked institution, and sort of the high rankings across.
Hey, Dr. Dunn, sorry to interrupt you. I think your slides are not advancing on the share screen.
Oh, can you see that?
I just see the title slide, unfortunately, and hasn't advanced beyond the first one. I think if you go to presenter view down in the corner, it might fix it.
Yeah, that's what I was doing there. Is this advancing?
No.
Okay. How about that?
Yes.
I'll just do that then. Like I said, Barnes is a huge hospital, and it's sort of the flagship hospital of a very large academic healthcare network. The Children's Hospital really is sort of the same prominent pediatric hospital as the Barnes Adult Hospital. It's physically connected. I'll talk about that in a second. Also a very highly ranked children's hospital and a great experience for our trainees as well. And our cancer care is embedded in a structure called the Siteman Cancer Center. And this is actually not a very old cancer center. It's 21 years old now, but it is a National Cancer Institute, what's called Comprehensive Cancer Center, which is the highest designation that the National Cancer Institute gives to cancer centers at institutions like ours. And it is a rapidly expanding program, and it, like the rest of the campus, has undergone significant physical plant changes, which is really shown here in this slide. When I was a medical student here quite some years ago. I mean, the campus is completely unrecognizable now, both at the medical school side of things and the hospital side of things. We're looking east at the hospital here. This is just an expansion called Parkview Tower. The Children's Hospital is expanded. The adult hospital is opening a new tower in a few years from now. So we have a lot of ongoing building to expand our infrastructure here. Another exciting part of that is what the medical school and the partnering BJC is doing on the research side of things. And this is a new neuroscience research building that has been slated to open in 2022. And I'm not going to play the entire video here, but you can just see that this is in close proximity to our campus, and it looks like a very modern research building. I'm just going to kind of scroll through this, and you can just generally get the sense that it looks very modern. It's connected to everything else. It's a very wide, open physical plant, and will be a tremendous asset to the institution and by extension to the department. So that is opening in a couple of years, and a fairly affordable price tag of $620 million. And one thing about St. Louis is that there is a lot of room to the west of us. We're bordered by the Mississippi River on the east, but there is a significant effort to also expand what we're doing, what we call in West County, which is just the part of St. Louis County that's to the west of the city of St. Louis. We have a new hospital there, the Barnes-Jewish West Hospital, where residents cover, and we'll have a significant spine experience there, both inpatient and outpatient. So I would summarize all this by there are significant institutional resources here, and all of them are expanding, which is very exciting when it comes to our department. This is actually what that expansion will look like. This area of green is called Forest Park. That actually separates the undergrad and the medical and hospital center. But when you look from the park east, then you see really an entire several block expanse of what these new physical plants will look like. So that is what you would be working in the near future. So let's talk about our program. Those are really the resources that our program leverages. So we had a chairman change within the last year, and our former program director, Dr. Zipfel, became our new chairman, and he has been in place for just over a year now. I then became the program director and stepped into some of his very big shoes in that role. And then Dr. Osbun became our associate program director. And we take a very team-based approach to all of this and really mutually make all of our decisions together. And again, we're joined by Sophie Church, who's our coordinator. So that's our kind of leadership triad there. We take 3 residents a year, and really, that's the really fun part of being involved in the program leadership. Really, is a resident. So these are just the profiles of all the residents here, from our newly started interns to our newly started chiefs. It's a great group from a span of medical schools and undergraduate institutions. But no question, this is the best part of being in the leadership structure is engaging with our residents and helping to build their careers. Those residents are really complemented by a pretty broad and deep faculty. We have 14 adult neurosurgeons, and that number is going to be augmented by 3 in the next couple of months here. So have added a couple of folks, which we'll get to in a second. We have a large pediatric group of five neurosurgeons. We have a growing group of basic scientists who are also housed within our department, and then a number of faculty you can see here that have joint interdisciplinary appointments with other faculty as well. And this is a picture of our faculty here, and actually all of our new faculty here represented as well. And we'll touch on each of these faculty as we go through the programs, but this is just sort of the baseball card picture of who is represented in our faculty. We have, and I think you got a sense of that from just the capacity and size of Barnes-Jewish Hospital. We have significant resources clinically to operate 6 dedicated neurosurgery ORs with, that's 2 intraoperative MRI rooms, and then 2 dedicated pediatric neurosurgery operating rooms at Children's. We have a new laser intraoperative OR suite that's opening next year, so that you can see that capacity will expand significantly. We do a lot of surgery. It's about 3,400 cases a year, nearly 1,000 pediatric cases, and then a growing number of both Gamma Knife and also Varian Linac-based radiosurgery cases a year. And Dr. Osbun will be able to touch a little bit on, how the endovascular volume, which our department is significantly involved in, adds to these numbers as well. Now, like I said, Dr. Osbun and I are going to tag team back and forth here. So I'll transition to him so he can talk a little bit about the vascular program.
All right, so we've got a very robust vascular program. Still do quite a bit of open surgical vascular disease between aneurysms, arteriovenous malformations, carotid artery disease, and moya. We see about 200, 250 aneurysms a year between open and endovascular. We're clipping, anywhere between 40 and 75 aneurysms a year still. A handful of AVM and dural AV fistula surgery, and as well as a few bypasses for moya. I'd say our CA volume here is a little bit out of date, and we're probably significantly higher than that since I've been here the last few years. And we do a robust number of CEAs, mainly for symptomatic carotid disease. We've got a very robust endovascular program. I'm the fellowship director for the endovascular fellowship, and we are consistently doing between 12 and 1,500 diagnostic angiograms a year between myself and 3 partners in interventional neuroradiology. And we do between 400 and 500 interventions a year, including stroke, aneurysm treatment, embolizations of various vascular malformations and tumors, and then a few kind of oddities such as venous sinus stenting for pseudotumor cerebri, and some other diseases we help ENT out with. So I think we have a very rich vascular experience, and certainly have rotations to get your feet wet in endovascular early on in the residency, and opportunity to do a little bit more focused interest in that later in your residency. You go to the next slide. I think dovetailing into vascular is the skull-based program. Certainly we have a rich skull-based surgery team that's mainly led by Dr. Chicoine and Kim, and then Dr. Ziffel and myself do a decent amount of skull-based volume a year. We have great partnerships between what I think is 4 key services. One is ENT, which includes both anterior and lateral skull base, ophthalmology and oculoplastics, in order to help do some of these cranioorbital lesions. And then plastic surgery for various free flaps and coverage of various radical exposures we do. And then of course the endovascular team for knowing if some of these skull-based lesions are encasing major vascular supply to the brain, and then doing some preoperative embolization for some of the more complex tumors. So amongst all this, again, a very rich skull-based experience, but I think four very skilled surgeons.
Yeah, I can completely agree. Now that I think the skull-based program is sort of enfolded into our larger general brain tumor program, which has experienced a lot of momentum in the last few years, and we're actively recruiting a basic scientist to lead our brain tumor center research effort. Clearly within the brain tumor program are significant efforts in both malignant and some of the benign diseases that Dr. Osbun just talked about. We see a lot of tumors here. This is a very large referral center. And again, that's complemented by some of the radiosurgery we do for metastatic disease. And the intraoperative MRI, 5-ALA, awake surgery. I mean, I think we have really all the contemporary laser ablation, all the contemporary tools of brain tumor surgery really are done at a high volume here. Dr. Kim, Dr. Albert Kim is the director of our program, and then myself and Dr. Mike Chicoine and also Dr. Osbun and others are key players in that as well. We have just sort of the next few areas here. I think you'll sort of see the pattern that really all of the subdisciplines within neurosurgery are covered with deep expertise. That includes the epilepsy program. We just recruited Dr. John Willie away from Emory, but actually he's coming back here because he was a resident here some time ago. He will actually lead the functional epilepsy program. He's going to come next month. But really, all of the complex, cutting edge things you do for those programs we do here, and I think he in particular will integrate laser ablation for epilepsy as well. But Dr. Dowling, Dr. Luthard is a big player in that space, and Dr. Smith on the pediatric side as well as, again, Dr. Willie, who's a new director of that program. That, of course, is integrated very well with functional, where both radiosurgery, laser ablation, DBS, and other procedures are part of the tools that Dr. Dowling, Luthard, and again also Willie will employ in these diseases, and again, and also high volume in that space as well. I've mentioned laser a few times, and I think most of you are probably familiar with that by now. The laser ablation or laser interstitial thermal therapy is an MRI-guided laser-based approach for thermal treatment of both tumors, but also non-neoplastic conditions like epilepsy. WashU has really done a very high volume of these cases and has been field leading in that area. We have a laser center. We have new intraoperative laser dedicated suite opening in 2022, and Eric Luthard has really driven a lot of that. I think John Willie will do that as well, especially on the functional side, as has Albert Kim. Again, we do a lot of procedures for pain. This is really led by Josh Dowling and also T.S. Park, our prior chief of our pediatric neurosurgery effort. That's microvascular decompression, the appropriate implants for spasticity, ablative procedures. In particular, on the pediatric side, we have a global referral program for selective dorsal rhizotomy, which has been an incredible effort by Dr. Park and his team for really many years. We've experienced, continue to experience a lot of growth in our spine program. That is led by Dr. Ray, Dr. Zach Ray, and also a number of Dr. Dorward and Dr. Santiago are joined by two new members, Dr. Camila Molina from Johns Hopkins and Dr. Pennycook, who trained at Cornell and did a fellowship at UCSF. So they're our newest members. I think we're going to continue to grow this program quite significantly, but really all of the contemporary complex spine pathologies and also approaches are really represented by this team. The peripheral nerve program is led by both by Dr. Ray on the adult side and then Dr. Park on the pediatric side. We now have a peripheral nerve fellowship, which is actually filled for quite a few years to come, which I think just reflects the work that Dr. Ray has done in this area. But I think in particular, he has actually developed a significant expertise in nerve transfer for spinal cord injury, which actually drives a lot of his research program as well. But this is a very growing and robust area, and also an important area in our neurosurgery program. And also, it's last but certainly not least, we have a really big pediatric program that really addresses all of the complex pathology that you see in this patient population. This is a group that approaches nearly 1,000 cases a year, which is a significant volume for a pediatric center. This program's had a pediatric fellowship for quite some time, And Dr. David Limbrick, who is one of our vice chairs, is the director of pediatric neurosurgery, joined by Dr. Park, Dr. Smith, Dr. Jen Straley, and also Dr. McAvoy, who I mentioned earlier, has kind of assembled this WashU virtual program. This is a terrific group, and the residents have a great experience with them. So that's our clinical program. And our clinical program, really, I would say, is seamlessly integrated with the academic mission, and particularly the research that the faculty do here. And I think it's really something special about our program. We have a lot of NIH-funded investigators, and I think that's actually one of the highest percentages of NIH-funded faculty in the country for any neurosurgery department. I'm listed first here, but I think that's alphabetical, and I am interested in how the immune system recognizes tumor cells. My lab is NIH funded, and also Dr. Kim has a significant effort in brain tumors as well. Dr. Luthart in functional and BCI, or brain-computer interfaces. Dr. Limbrick studies both Chiari and hydrocephalus, which is a great example of studying the patients that you treat. He has significant funding as well. Dr. Ray is well funded in the peripheral nerve and neuroprosthetic space. And Dr. Straley, right here is Dr. Straley actually in the neonatal intraventricular hemorrhage, the CSF dynamics, the role of iron in this process. She does a lot of very, very interesting work there as well. Dr. Smith is also very active. And I will add that we have several additional scientists who are not clinicians, but basic scientists. Dr. Yano, who is an epigenetics scientist. Dr. Zippel, of course, our chair, like I said, this is alphabetically listed, also has significant research funding in amyloid angiopathy and also subarachnoid hemorrhage-induced ischemia. And I would just add to the slide here that we also have recruited recently Dr. Allegra Petty, who is a basic scientist in single-cell sequencing. And the department is also recruiting the head of our basic science head of a brain tumor research center that is, again, speaks to the momentum that we have in that space. Dr. Osbun will now talk a little bit about some of the details of just the way that our residency is structured and just what our setup is that's unique to WashU.
Okay. Thank you, Dr. Dunn. So just quickly about resident research mentorship. Everybody will get at least 18 months of protected research time, and then we have a structure to allow you to apply for 24 months of protected time for those interested in maybe doing a little bit less clinical time and more time on research. We have a very productive group of residents, and we're a top 10 program in H-Index for residents. And then we have a quarterly neuroscience research mentor group meeting where we really mentor our residents through developing their research projects for the PGY 5 and 6 year, help them apply for grants during the process, and really teach them in their first 3 to 4 years of residency how to complement their clinical interests with some research interests. So the goal is to not leave the trainees high and dry and tell them, go out and find a lab and figure out how to apply for funding. We really want to teach grant writing and finding funding resources and developing your project in a way that's going to complement your academic career. And I think we have a really nice structure for doing this. And whether you're somebody with a PhD or has never worked in a lab before, I think we have examples of successful residents, on this pathway from both backgrounds. And then you can see some of our funding resources that our residents have commonly gotten. And then we have an institutional R25 grant that can accommodate between 1 and 4 residents a year here at the institution, which many of our residents get funded through. Okay, next slide. We've got several recent first author resident publications in these journals. Our residents are always publishing and being productive. Next slide. And then I'm going to talk a little bit about the residency structure. You can advance. So we're a 7-year program, 3 residents per year. This includes a 12-month neurosurgery internship, which is approximately 6 months of dedicated neurosurgery or neuroscience rotations, including neurology and the neuro ICU experience. Then we have 24 months of junior residency between the second and third years, where you'll be rotating mainly on the adult service through subspecialties of tumor, vascular, functional, and spine. And then that includes between 4 and 6 months of a pediatric experience. And then there's 12 months of senior residency during the R4 year, which will be again split between adult service and then being a senior resident at the Children's Hospital. We have at least 18 months of protected research time. And again, we can accommodate at least 1 resident per year applying for a 24-month track. And then some of the clinical rotations and the PGY 2 through 4 year will get contracted a little bit. And then at some point during the 5 and 6 year, our residents get a 6-month experience in Ireland at the Royal Beaumont Hospital, which is one of the most, favorite rotations any of the residents do. And then finally, it's capped off by 12 months of chief residency, which is really an experience in leadership and just extremely high operative volume. Next slide. For the expanded investigator track, which again is our 24-month research track, it will go from approximately January of the PGY 4 year through December of the PGY 6 year. The goal is to maintain the rotation in Ireland, and we accomplish this by incorporating standard research rotations into the 24-month research time. And there will be a couple small reduced clinical rotations, such as the endovascular rotation, and maybe some shortened time in some of the junior resident rotations in order to accomplish this. And then we ask our residents to submit a formal proposal to enter in this program at some point during the PGY 2 year. It's not something you apply for in the match at a medical school. This is something you would decide during your residency. And then we'll see if we can accommodate the individual research plan or not, depending on what your 2 co-residents are doing that year. Next slide. Our adult rotations, we used to have 5 adult neurosurgery teams. We've now contracted to 3 main teams. And so basically we run our adult service with 3 chief residents and 6 junior residents. So now that means that each chief resident has 2 junior residents. And so we now have a vascular and functional neurosurgery team for 1 chief resident, a tumor team for 1 chief resident, and finally a spine focused team for the 3rd chief resident. Each of these will have 2 of our junior residents rotating through. Call is in-house between the PGY 2 and 4 year, and we're now on a Q6 call cycle. For 24-hour in-house call. Both our children's rotation and our chiefs do home call. So it's approximately Q2 for the children's rotation, approximately Q3 for the adult chief call. Next slide. We have 1 pediatric team, which includes 2 residents, a PGY 3, a PGY 4, and then 1 pediatric fellow. And then again, that's home call approximately every 2.5 nights because the fellow takes some of the call and then splits the weekend coverage as well. Meetings and courses. Here at Washington University, we have an annual resident symposium where we have a visiting professor, about half a day of research presentations from the residents. And then time with the visiting professor, and then usually a dinner at the end of the day. We have several annual spine and skull-based courses that is industry sponsored. We have a wonderful skull-based lab now in our main office building that we share with ENT. There's plenty of cadaver heads, so you can go practice approaches either during the course time or really any time on your own time. where you've got extra time, you can always go up to the skull-based lab and practice approaches. We have real drills, any instrument you could want that you would see in the operating room to practice on cadaver heads. And then we have similar spine courses where we kind of have these hemi bodies that have a full spine still implanted, where you can practice screw placement and exposure of spines. And then nationally, there's several meetings that you can attend, provided that you have a presentation to give, and then several cadaver courses nationally that we commonly send our residents to. Next slide. And then finally, the Ireland rotation, which happens sometime during the PGY 5 or 6 year, is 6 months in Dublin, Ireland at the Royal Beaumont Hospital. We're able to provide our residents a very high level of autonomy during this rotation, where they really get to operate independently, manage patients in clinic and the emergency department independently as the primary surgeon. It's a wonderful experience for life, for understanding healthcare in another country with different financial pressures. And our department covers the cost of travel, licensure, car rental, and then you're paid well by the National Health Service in Ireland during that time. Next slide.
Great, Josh. I'll just finish up here and just point out that a lot of our graduates are certainly now completing fellowships, and really they're getting the elite fellowships that they're applying for. I think if you just look at this list for all of those different conditions, they really are transitioning to fellowship training, which clearly is a trend nationwide. And then over the last 20 years, the majority of our faculty are academic, and certainly more recently as well. And then a certain percentage going to private practice. We've had some active duty military as well. And then we live in St. Louis, and St. Louis is a great and easy place to live. And I think if you're from the Midwest, then you know what some of those advantages are living in the Midwest. If you haven't been to the Midwest, then you should come and try it. And just obviously we have professional sports and concerts, and I just point out a new Major League Soccer team here as well. But that concludes really the slide-based part of our presentation here. We're really excited about we've sort of had a leadership transition in the department from a chairman who was here for 30 years, but there's just a lot of momentum and excitement about the foundation that Ralph Dacey, our former chairman, built, and where Dr. Zippel is taking things. And we've got a great group of residents and a really talented group of faculty, and we're excited about where we're headed. But we've got some time left here, and that was intentional. Feel free, anybody, to ask us any questions that we can to help you think about our program a little bit.
Hey guys, thanks for putting this on. My name's Joe. I'm coming in from Albert Einstein College of Medicine, New York City. I was really intrigued by the research track for the residency, and also great presentation. Thank you. I'm curious, since the applications are due in PGY2, what the process is for advising and putting together an application, and where the residents find time to do that.
Yeah. Hey, thanks, Joe. And certainly, I want to acknowledge Sophie for putting a lot of that great presentation together. So the process is some of your question really got to sort of what is the mentoring that kind of goes into someone thinking about that and applying, and I think and I'm glad you asked this question, because I want to use it to emphasize again just how many of our faculty actually have a research program that is ongoing. It's not like one or two, or it's kind of an odd thing to try to be doing as a PGY2. So that's just part of our culture. So I think that people are very keen to mentor interested residents, and if if you're someone who's applying for that, then you'll get all the mentorship you need, because that's just what a lot of our faculty and residents do anyway. But they're very good collegial relationships between our residents and faculty, and so it's very people just are excited to help residents through that process. So and as you pointed out, and Dr. Osbun mentioned, it is something that kind of takes place at near the end, or the spring to near the end of your PGY 2-year. And the way it works out is that out of 3 residents, not everybody wants to do a dedicated, have that extend to a full 2 years. So we really haven't seen any issues with that being sort of really conflicted. So the people who are really wanting to go that pathway tend to gravitate towards it and have all the mentorship in the department they need to do that.
Thank you so much. That was really helpful.
Thank you both for putting this presentation together. I had a question about the PA support, and can you just speak a bit more about what kind of PA support you have at WashU?
Sure, I can take that one. So I'm a medical director of the inpatient NP service. We actually don't have any PAs in the department, but we have now 9 inpatient NPs with hopefully getting a couple additional slots for that team soon. And then 4 outpatient NPs right now. So I'll be honest with you, the outpatient NPs are not going to affect you too much as a resident, other than possibly being a resource to help get patients seen on short order in a faculty clinic. But the inpatient team is immensely helpful to our resident team every day. They do the majority of the floor management and certainly discharges, managing consults, studies, and even note writing during the day. So we usually have 3 to 4 nurse practitioners on per day to cover our inpatient neurosurgical service. And that's really geared at, having you round and get the plans initiated in the morning, and then getting to spend the majority of the day in the OR, rather than, discharging floor patients and managing consults on floor patients. So I think we've got fantastic mid-level support for our residents on the inpatient side. And the NPs are there to help you and certainly enhance your time in the operating room and surgical skills.
Thank you.
Thank you, Dr. Dunn and Dr. Osbun, for a great presentation. That was really insightful. I had a question regarding clinical electives for residents. So it sounds like the 18 to 24 months for the research time is pretty dedicated. Are there opportunities for residents to pursue enfolded fellowships, or are they primarily encouraged to do that after residency graduation?
So we do have an opportunity to do a majority, or not majority, but a significant portion of an endovascular fellowship during residency, but it still requires a 1-year postgraduate fellowship to complete. So we do have several residents who have gone into endovascular fellowships, do 6 months dedicated sometime during the PGY 5 and 6 year. That's certainly going to get your diagnostic angiography requirements out of the way. But we have not had anybody complete an endovascular fellowship within the 7 years, and our residents have gone on to then do a 1-year postgraduate fellowship.
Great, thank you.
And other than that, we don't have any president for enfolded fellowships, and our residents have traditionally done postgraduate fellowships.
Can you guys give us a few specific examples of research projects that residents are currently working on? And then can you guys also touch on sort of the protected aspect of the research year? So does that truly mean that there are 0 clinical obligations during those years, or are residents still expected to cover cases and take on just a few?
No, those are two great questions. So I'll answer the second question first, because that you're drawing out a really important point. And so what some of the lab residents, if for example, a chief resident goes on a job interview, then the lab resident may cover the cases for that day if that person misses it. That's the extent of their clinical requirements. They do not take call. They're not, they really are about as protected as you can possibly be. So that word is very real when it comes to the dedication of their research time. Now, the first question, really, those research projects really, run the gamut. And just sort of off the top of my head, I mean, Jacob Greenberg has sort of a extremely well-funded national pediatric head trauma database that's more sort of on the clinical research and outcomes and data science side of things. Bhavik Patel is working on sequencing of skull-based tumors and combining laser ablation with immunotherapeutic approaches, which is both with Dr. Kim and a little bit with myself. Rupen Desai is working on focus ultrasound and liquid biopsy approaches. Some of the residents who've just gone into the lab are looking at functional connectomics as it relates to vagal nerve stimulation and also spreading depolarization and subarachnoid hemorrhage. And then prior residents have looked at nerve transfer and also kind of biologic ICP monitoring. That was actually a Nature paper. So really a whole span of research efforts. Some of those are hardcore basic science. Some of those are using preclinical models and things like that. Some of those are hardcore basic science, but using tissue and cells derived from patients. Some of that is sort of directly translational, and then that goes all the way to the outcomes, data science, and I think those residents, the outcomes and clinical research and data science folks, have actually leveraged kind of obtaining a formal master's in science and clinical investigation during that research time to kind of like those are tools that I don't have. So certainly we have resources for them to formally train that both will help the research projects that they have ongoing and also leverage into their academic programs as faculty.
Thank you.
I think we have a little bit more time for additional questions.
Hey, I have a question.
Go ahead.
So I'm curious, during some of the research years, I'm wondering what kind of flexibility there is for formal training in certain types of research. Like, for example, getting a master's degree in either biostatistics or clinical research, something of that nature.
So there's a good opportunity for that. WashU in particular has an amazing biostatistics core, and they have 2 specific degree programs looking at research design and biostatistics. One is more of a big data degree, is what I would say, and it's called a Master of Population Health Sciences, or MPHA. And that one really teaches you how to work with big administrative data sets and do a lot of complex statistical analysis out of it. The other one is the MSCI, or Masters of Science in Clinical Investigation, and that one is sort of about half biostatistics and about half research design. And that one has a lot of flexibility to make what you want it and what you want to get out of it. So there are a few core courses in biostatistics and research design and research ethics, and then you can do all sorts of complex courses in statistical modeling, bioinformatics, genomics, translational medicine, even coursework in sort of entrepreneurship and taking devices and drugs to market. That degree is very versatile, and outside of its kind of core, 12 to 15 hours of coursework, the remaining 15 hours of coursework is completely elective for you to make the degree what you want to get what you need out of it. And that can be done in 1 year. And we've had a few residents get that in the past.
Cool, thank you.
And then I'll mention we are also starting, I don't know if it's up and running yet, another master's degree in bioinformatics, and we have a large bioinformatics core that just got started as a sub-institute within the university about 4 years ago. And they have an official degree program up and running now, which I think could be an interesting opportunity as well.
We have a large kind of genomics presence at WashU, so I just would dovetail what Josh was saying. Something like that, if you're actually doing a genomics project, I think that would be a really interesting and kind of practical opportunity to accelerate your work and your expertise.
And the other thing I'd say is you don't necessarily have to get a master's in one of these programs during your research time. You can just take some of the coursework to support the project you're doing and, you know, learn either a statistical method or a lab method or whatever you might need that's going to support the project. And we also have a president of our residents just getting, you know, a couple individual courses supported on their grant funding. So.
Great. I think we one last burning question, and then we'll let everybody keep going with their Sundays.
Can you talk a bit about how you screen applications, and given this situation this year, how you're planning on conducting interviews?
Just to make sure I understood the question, was the question, you know, how we as a program look at applications?
Yeah.
Yeah, I think that you know, we look for academic excellence and look for residents that, you know, we think would be great neurosurgeons and that want to train here. You know, we don't have sort of very kind of rote check boxes of things we're looking for, and I just would kind of make that point first of all. We sort of look holistically at each applicant. You know, you think about what actually comprises the application in a medical student applying for residency. I mean, it's sort of what you've done over your whole life, not just what you've done over the last couple of years in medical school. And that sort of, you know, it forms the person you are. And so clearly, you know, I'm not going to say that your scores and your grades, these things are not important. I mean, they reflect your ability to excel academically and perform academically. That's just a part of what the composite picture looks like. You know, what have your experiences been? You know, I mean, we look at your and read every word of your personal statement. You know, that sort of can really draw out what someone's journey in their life and their lives has been. So, and then the letters are very important too. That helps kind of fill out dimensions that we may not necessarily get from just looking at the standard ERAS. So that's not, you know, that's not sort of a checklist answer, because we don't really take a totally checklist approach to it. I mean, your application, you know, we try to form into what a three-dimensional representation of you might look like, and we really take it from there. But, you know, we're trying to train neurosurgical leaders and people. You know, we want to train really, really outstanding and really the best neurosurgical residents that we can train. And so, you know, we want to really train excellence.
Thank you.
I just want to add one last comment, because there are no residents from our program on this, and I know that Dr. Dunn and Dr. Osbun will not say it themselves. But I have to tell you, having been the coordinator under Dr. Zipfel, who is wonderful and extremely interested in resident education and passionate about it. You know, every transition you sort of don't know quite what to expect. All of the alumni that we told, when they knew Dr. Dunn, Dr. Osbun was a more recent addition, so not all of them knew him, but they were all extremely happy when we told them that Dr. Dunn was taking over. And our current residents are so thrilled with both of them. They have their backs, they know that. They're very passionate and eager to always work on improving the program. It's nothing is a one-sided decision, from the top down. It's a discussion with the residents, and we want their input as well. But really, I've worked with a number of different program directors from neurosurgery, but also from other specialties. They are who you want in your corner.
Wow, thanks, Sophie. I did not see that coming. You're right. We wouldn't have said that about ourselves, but we have a really good team, and I would just sort of summarize one aspect of all of this is that and I just don't think you will. You may not see this every place, but the residency is the most important thing in our department. Our department is centered around the residency program. It's always been that way. We enjoy it. And again, I just echo a couple of things when what Sophie said. I mean, we really spend a lot of time thinking about the residents, and sometimes your training is not always a straight line, but the residents make it really, really enjoyable to be a part of the program leadership. And everything we just talked about in our slides. I mean, training is dynamic. We're always adapting and thinking of new and creative ways to build our program and imagine it to be the best it can possibly be. And so, and the hierarchy of ideas to do that is flat. Somebody may come up with something next week that we just hadn't been, especially with some of our new faculty members from Emory and Hopkins and Cornell and UCSF. I mean, they may have seen some things that we need to borrow. And so these slides that's like a living presentation that's going to change a little bit each year as we kind of continue to reimagine how to have our program be the best it can be. I think that'll do it. Well, look, thanks so much for getting on the call on a Sunday afternoon. Really appreciate it. We've enjoyed here. You guys asked really great questions, and thanks for tuning in. And there are a number of these other types of topics that will be covered at the same bat time, same bat place by Dr. McAvoy and his team. So I think this is sort of well advertised on Twitter, etc. So stay tuned, and there's sort of more to learn about our program. So again, thanks for tuning in, and nice meeting all of you virtually.
Thank you, everyone.
Thank you so much.
All right, you bet.